So good morning, good afternoon, and good evening. APMEN Joint Working Groups and Interest Group Update 2025. Many presentations from the Working Group and Interest Group as a back-to-back, followed by a Q&A session at the end. APMEN is a sustainable and collaborative network institution to work together for the malaria elimination in Asia-Pacific region. So in 2008, Australia Prime Minister, the Honorable Gavin Roth, announced the launch of the APMEN in UN General Assembly. In 2009, the first APMEN meeting was hosted in Queensland with 10 founding countries with the support of the WHO, GMP, CRO, WIPRO, RBN, ACT Malaria, and other technical institutions. At the time, APMEN has joint secretariats hosted by two institutions, University of Queensland and UCSF. From the first meeting, Water Control and Vivax Working Group were formed. You can see that a lot of logo at the bottom of the slide. It shows that the hosting institution for these two working groups. In 2010, APMEN established the fellowship program. Within 5 years, 27 fellowships were awarded. APMEN has generated a lot of evidence, including more than 70 scientific publications. And since 2010, biannual APMEN advisory board meeting were convened. So APMEN 2 meeting, that is annual general meeting with the study tool, was done in Sri Lanka. In 2011, Thailand joined APMEN. And one highlighted project is the APMEN Atlas project. So there's a lot of map in the website of the APMEN Atlas project. And APMEN 3 meeting with study tool was done in Sabah, Malaysia. So since then, annual meeting of the Water Control and Vivax Working Groups were conducted. You will see that some photo Honorable Minister from the Malaysia and also fellowship awarded to the fellowship in that photo as well. So in 2012, another 3 countries joined APMEN. So I noticed that more than 20 case studies were developed to share the country program experience across the network. APMEN 4 meeting was done in Republic of Korea. And a study tool, you will see the photo. The participants are walking across the bridge in the demilitarized zone with bordering with DPR Korea. In 2013, APMEN Selfless Response Working Group were established in APMEN 5 meeting. So you will see 3 institutions who are hosting and hosted the working group. One highlighted project is that APMEN nominated and supported participants to attend the Science of Eradication courses of the WHO. This is one of the highest malaria courses. In 2014, another 2 countries joined APMEN officially. So since 2014, country partner technical development program were started. That is a research project to the country program. So 30 programs, research projects were funded since then. One highlighted project is that RBN PNI series. So they published for the APMEN to share their APMEN experience. APMEN 6 and study 2 was done in Palawan, Philippines. So at the top right corner, you will see the declaration. So 12 country program representatives signed the commitment to reduce the malaria to the 0 indigenous cases by 2025. So nowadays, you notice that China, Sri Lanka, and Timor-Leste already eliminated, and Bhutan and Malaysia has 0 indigenous cases for more than 3 years, and 3 GMS countries and Nepal are very close to eliminate. In 2015, India and PNG joined the APMEN officially. So since then, annual meetings for SRWG were conducted. APMEN 6 was take place in Vietnam. 2016, another working group, program management working group were established, but it will not be no longer because of funding situation. And we have the APMEN reference group meeting. Now we got trilateral working group meeting are regularly conducted. So APMEN annual general meeting, since 2016, there's no more. We got APMEN 1, 2, 3, 4. We got the APMEN annual general meeting. So it was held during the Malaria Week event together with APMEN. In 2017, APMEN and APMEN was signed the MOU to do integrated under the new working environment in Singapore. An APMEN general and business meeting was held in Malaria Week together with APMEN in Naypyidaw, Myanmar. Since 2017, ORIN website targeting the entomologists to exchange the knowledge sharing was established. In 2018, MVSC course was started. So this is a 2 weeks intensive course, including the free practices. So now these 6 courses train 135 entomologists from 21 APMEN countries. We have one training focusing on Plasmodium knowledge. And another one meeting is that if the joint working group and partner coordination meeting happened in Bangkok, Thailand. In 2019, Afghanistan, Myanmar, and Pakistan joined APMEN officially. APMEN provided scholarship to attend the diploma course in applied parasitology and entomology course in Malaysia. So APMEN meeting was done together with APMEN in Malaria Week in Bangkok, Thailand. 2010, because of the COVID, we could not do the in-person events. So APMEN established a webinar. We got APMEN Tato and APMEN Exchange webinar. Now we reach 57 webinars and attended by the 11,000 individuals from 130 countries. And community engagement and private sector engagement were focused since 2020. So APMEN annual meeting was done together with APMEN. It's an online Malaria Week meeting. In 2011, APMEN started virtual training courses. There are a lot of virtual courses. Some are open for only national malaria program from 21 countries, and some of them are open for everyone. In total, there's a lot of training and reaching the more than 3,000 malaria professionals worldwide. So one highlighted course is online vector surveillance course. Even in 2015, course attracted 2,700 people from the worldwide. In 2022, technical support initiative from the SRWG was started, and in-person annual working group meetings resumed after the COVID time. In 2023, the last country, Timor-Leste, joined APMEN officially. In 2023 meeting, 3 APMEN interest groups on climate and environmental change, border malaria, and outdoor transmission were established and endorsed by the country program and partner institution. Peer-to-peer knowledge hub launched in 2023. In 2024, APMEN catalytic technical support fund provided to the 2 countries. This is a small-scale technical support fund, which are not funded by other institutions. SRWG support the development of dashboard like SysMod in Indonesia. So one successful meeting is the APMEN joint Vivax SRWG meeting in Kuching, Malaysia, attended by the more than 110 participants from the national program and partner institution from 21 countries. In 2025, peer-to-peer exchange on border malaria between Indonesia and Malaysia was initiated by SRWG and border malaria interest groups. This is the first ever meeting for the 2 countries for malaria. And climate workshop was held in Singapore to address the adaptation strategy on vector-borne diseases. And one highlighted project is that a dissemination workshop for the GCPD pilot project was conducted in Pakistan. So this is my last slide. I would like to introduce, you may know that we have the 3 working groups and 3 interest groups. So working groups have the 3 people. One is a chairperson from the National Malaria Program. and co-chair and coordinator from the hosting institution. So because of the limited space, I could not include the coordinator photo. So for the surveillance and response working group, Dr. Ina from Indonesia, she is now currently on leave. And Professor Richard and Marina from Moru. And for the Vata Control Working Group, Dr. Muta from Pakistan chaired the working group. Dr. Leo is co-chair and Hulan is coordinator for the working group from Malaria Consortium. And Vivax Working Group, Dr. Nina from India is chaired the working group, and Dr. Caroline is a co-chair and Manish is a coordinator for that working group. In addition to that, we have 3 interest groups. Those are cross-thematic interest group managed by the working group. So climate and environmental change interest group is chaired by Dr. Kimberly from NUS. Water malaria is chaired by, again, Dr. Professor Richard from Moru. And outdoor transmission chaired by the Dr. John Kevin from PhD IMR. So thank you very much. And I would like to hand over to the SRWG. So Professor Richard and Marina, could you please present about the SRWG? Over to you. Thank you.
Thank you, Paul. I shall just share screens and then we'll start. Great, thanks very much. So hello, everybody. We'll go into a bit more detail about what we've been doing under the APMEN SRWG and a little bit about what's coming next. So start with some background. We've been hosting since the beginning of 2021. And we have this objective to have a connected and mutually supportive network that fosters sharing of expertise and development of capacity to accelerate malaria elimination across the Asia-Pacific region. And we've had 3 chairs from national programs. So Dr. Ratanasai Petsivan started off 2021 and then succeeded by Professor Xiaowen Chu. And then in 2025, Dr. Ina Agustina Isturini took over. So Dr. Petsivan from Laos, Dr. Xiaowen from China, and Dr. Ina from Indonesia. And then there's a picture of Marina, who's the person that does most of the work. She's the coordinator and program and the manager. She's sitting next to me here. So we have 3 key pillars. The first one is knowledge sharing and technical advocacy. We have pillar 2, which is capacity building and technical support, which includes capacity strengthening for national programs and then peer-to-peer support. And then pillar 3 is coordination, which spans annual meetings, South-South collaborations between countries and national program consultations, and much more besides. So we've been busy the last few years. This is 2021 to 24. We've been sustaining malaria community health worker programs in the Asia Pacific with an evidence base. So we've had quite a lot of research to look at how best to sustain these programs. And that's been shared quite widely, and it's involved quite a lot of the countries across the region. And we've been working on geo-enablement, which is strengthening health information systems, particularly focused on malaria for different countries across the region. So we've done a survey to look at the baseline, and we've been providing some support to individual countries for that. We've done some work on use of climate data for malaria programs, particularly in the general meeting in last year. We've organized quite a few tech talks, and we've had the monthly newsletter, and then recently also some blog posts. Under pillar 2, we've been doing training needs assessments for national programs. So we started out with a formal survey at the beginning, and we've been keeping that up to date to drive what the main training needs are across the region to help us plan to deliver some of those training activities. We've been providing that technical support one-on-one to countries, including recently Papua New Guinea for this geo-enablement of health information systems. We've done online regional training on HIS geo-enablement. So that's covering lots of countries, and that work is going to continue. We'll keep running those training exercises. We helped organize a workshop on AI-enabled malaria control and prevention in China in 2024. And then we've had training workshop on spatial epidemiology and GIS for malaria programs, but focused on Indonesia. And lastly on here, we've had our annual meetings. So we've had both online and in-person meetings. We've joined the APMEN Leaders Summit and helped to host sessions in the Leaders Summit. We've been working with Vivax Malaria. They have a surveillance monitoring and evaluation working group, which is essentially the equivalent of our SRWG, but in RBM. Had a variety of collaborations. I'll talk a bit more about that. And then we've had a range of different direct consultations with different programs, which I'll mention a bit more. So just to go into a few of those things in more detail and to update for this year. So under knowledge sharing, we've been working on a regional consultation on data quality audits, data quality assessments, so looking at what countries are currently doing to assess data quality. So the objective is to document what's currently happening, which methods are used, to find some of the barriers and challenges and help share information between countries to help them learn, to see what's possible and what's being done in different locations. So we've been producing a report, so a cross-country synthesis of the main themes that come out from that, particularly the challenges and then innovations to try and address some of those challenges to assess data quality. And we'll be getting back to the countries that have participated with more detail of what information they've given to us. We'll have also some case studies. So a lot of the countries that joined were interested to be part of a more detailed case study, which we'll be sharing through the APMEN platform. And then we will be disseminating initially at the Vivax Malaria meeting, because this is part of a wider set of activities where they did something similar through RBM in Africa. So we'll be presenting to RBM and then comparing findings and seeing what the global themes are to try and lobby for more support to try and address data quality issues. So from this, we had 10 countries that participated, and we had very detailed information that came from them. So we've been working through distilling all of that and summarizing, ready to present back. So more to follow. We've been producing newsletters and then recently blog posts to support regional knowledge exchange. So that's documenting our activities and the progress, highlighting experiences from individual countries, and also amplifying some of the learnings from across the region. Just one example, but recently we've had Bridging Borders to Eliminate Malaria. So in the APMEN newsletter, particularly for the Border Malaria Interest Group, which I'll also talk about after this, that I chair as well. So we've been showcasing the interest group support, peer-to-peer exchanges and technical consultations, as well as bilateral coordination efforts. And we featured a couple of bits more detail from China and Laos as some examples. There's a QR code on there if you want to read that newsletter. So we've been supporting capacity building and technical support. So you heard Indonesia mentioned, but one of the projects is helping Indonesia's national program with strengthening the SISMA, which is the National Malaria Information System. So we've had a couple of meetings there, one technical meeting in Lombok and another meeting in Jakarta to help support the transition to the country ownership of that system. We've been also helping, and we'll be doing more to support dashboard sustainability for the national program. So we've done a bit of work with Okra ID, which is an Oxford University partner of Moru based in Indonesia, to strengthen capacity in Indonesia for designing and managing their own dashboards. So we, in this case, using Power BI. For coordination, we attended the APMEN Leaders Summit and helped to organize and moderate a technical session on cross-border collaboration for malaria. And we have a dissemination of high-level findings from this data quality audit study that I mentioned. So that's going to be happening later in this year. And then there's also been direct consultations with national programs on a few different topics like early warning system development, data quality, simian malaria, risk maps, integrated dashboards, and importation. And just some of the countries where that's been happening, I've listed here: Bangladesh, Indonesia, Malaysia, Solomon Islands, Thailand, and Vietnam. So I think lots to keep us busy over the coming months. We are updating the website pages on the APMEN website to include a knowledge repository. So this is expanding from the Border Malaria Knowledge Repository to be more generally about surveillance and response. We have plans for between country exchanges on early warning systems for malaria and dengue, and including exploring the feasibility of using AI for prediction and response. We have plans for more capacity building technical support, so particularly GIS and data analysis training, which is frequently requested by programs to strengthen surveillance and response for vector-borne disease more broadly. And then ongoing assistance to strengthen malaria information systems, including new tools and methods for risk stratification and integration of different data dashboards to be combined. And then lastly, we will have also, with the other working groups, the joint annual meeting next year, hopefully in Bangkok. So I'll go straight onto the border malaria interest group. And Paul, do you want to take questions at the end?
The question I thought would be at the end of the presentation. So please go ahead.
Okay. So Paul mentioned that we have this recently created special interest group on border malaria. So that's a regional platform currently hosted under the SRWG, established last year, and it's connecting national and subnational malaria programs, researchers, and implementing partners to address border malaria challenges. So it has a broad remit, but we've particularly been working on facilitating knowledge exchange, generating operational evidence, and coordinating technical and policy responses. So that includes also building partnerships and tools to facilitate countries to act collectively across shared borders. So a very important topic and ambitious, but certainly much needed. So we started out setting up consultation channels and then this border malaria knowledge repository. So that's included reviewing national strategic plans from countries, surveillance SOPs as well, to understand the baseline of how countries do surveillance, so how they define and classify indigenous and imported malaria cases. And there are differences in that between countries. So those differences affect how countries risk stratify and how they target interventions. And from that exercise, we're seeing the need for harmonized definitions and approaches. Also, having this shared repository will help align cross-border surveillance and response and should help with coordinated action. So we've been working on peer learning and technical exchanges, so strengthening country-to-country collaboration through joint meetings and peer exchanges to help harmonize surveillance and response either side of shared borders. We are expanding this repository with desk reviews, so collating all those documents and information, to the plan then being to make this available online through APMEN. And we've been contributing to regional consultations and preparing policy recommendations to support cross-border collaboration. So that's working with APMEN and WHO. So as Paul mentioned, we organized this cross-border meeting between Indonesia and Malaysia on border collaboration. So that included provincial and national malaria control program staff, disease control teams from both sides of the border, initiated through country-led requests. So this is something that they asked us to help with. And it included those different levels, but also the Director of Communicable Diseases from both countries and the heads of the vector-borne disease units and some research partners. And having those people in the room and having a very focused meeting enables us to go into some depth on nose-eye surveillance, discuss a bit about data sharing, and also more about harmonizing cross-border coordination. And we were able to produce together a joint roadmap for short and medium-term actions to help strengthen collaboration going forwards. For the knowledge repository from the desk review and the grey literature, so we focused initially on current malaria status and interventions in 4 key border areas and stakeholders, frameworks and guidance supporting cross-border collaboration. So working on a foundation for a policy paper that APMEN was writing, we've been gathering evidence to feed into that, to generate a set of key recommendations for the region. So the plan is currently we have a Google Drive, but we're wanting to transition that to the APMEN website, so to make that generally available and be able to maintain it and keep it up to date. So adding to that, for this policy paper, we've been doing some joint research with APMEN and consultation with the WHO GMP. So using a mixed methods approach with desk review, but also then mapping stakeholders and then interviewing key informants from across the region to gather evidence and stakeholder perspectives about border malaria. So the aims are to produce evidence-based policy recommendations for the 4 border regions to guide future collaboration. So the policy development being led by APMEN with lots of research evidence feeding into that that we've collected together, but Moru designing and leading the research component. So that will feed into a policy paper and a peer-reviewed publication, so coming next year. And that's it. If you'd like to find out more or get in touch, please email either myself or Marina. Thank you.
Thank you very much, Professor Richard, for your comprehensive presentation about the SRWG and border malaria interest group update. So I would like to hand over to the vector control working group. So Dr. Mutta and Professor Leo Barrett. So could you please present about the vector control working group and outdoor transmission interest group? Over to you.
Thank you, Dr. Pon, and also very warm welcome to our audience. Thank you all for setting aside time to listen in. The APMEN working groups and APMEN itself exists for your benefit. We are here to serve you, and we keenly look forward to your feedback, how you feel we can improve our service to you, our various target audiences. So before I start off with the feedback report, I'm going to ask our Vector Control Working Group Chairman, Dr. Mohammed Mukhtar, just to say a few words by way of opening and welcome. Dr. Mukhtar is the director in the Directorate of Malaria Control in Pakistan. He's in charge of all vector-borne diseases in Pakistan, not just malaria. So it includes leishmaniasis and lymphatic filariasis, arboviruses, and so on as well. Big task that he has, and he's an extremely productive, highly energetic person, and it's an absolute pleasure to work with someone of the qualities of Dr. Mukhtar. Dr. Mukhtar, if you are able to say a few words of welcome, that would be great.
Thank you, Dr. Liu, for your kind words, as always. And I also extremely thankful to all the participants who have joined us virtually across the globe. And as you mentioned that the Vector Control Working Group is providing the technical assistance, not to this region, but beyond these regions, to solve their issues related to vector control, particularly to achieve the elimination goal. So this is just to, I think you have mentioned everything about the Vector Control Working Group. It's a vibrant and very active working group, providing the technical assistance to all the member states, as I mentioned, that even beyond these regions, so that we can achieve our ambitious but achievable goal of malaria elimination, not only this region, but beyond these regions. So this is just, and I warmly welcome all those people who have joined us virtually around the globe, and I'm sure they will be benefited with what the knowledge will be shared through this platform, and definitely this will certainly help you to develop, to redefine or redesign their national policy strategy for vector control, and definitely it will be very benefit for everyone, and I'm sure that everybody will join us with a true spirit of professionalism and learning. And so this is just my thanks to everybody who joined us, and over to Dr. Liu for wonderful. I'm sure as I always, Dr. Liu always give a very, very good insight about the Vector Control Working Group of APMEN. So over to Dr. Liu, and thank you very much for your brief introduction. Thank you. Over to Dr. Liu.
Thank you for those words of welcome and introduction. Thank you, Dr. Mukhtar. So this is going to be a feedback on the activities of the Vector Control Working Group, and as is with any of our working groups, it's very much a collective teamwork effort. So I'd like to specifically mention here the key people involved in there. Dr. Mukhtar is our chair, Shobicha Wulan, who's our coordinator, and then, of course, Dr. Ponsi Hein, who is not just in charge of the Directorate of APMEN back in Singapore, but he's also a very, very active contributor to direct implementation and producing outputs as part of the Vector Control Working Group. I should mention that the Vector Control Working Group is also responsible for coordination, oversight of two interest groups, those being the Climate, Environmental Change, and Malaria Interest Group, which is run by Professor Kimberly Fornas at the National University of Singapore. Then there's also the Outdoor Transmission Interest Group, which is run by Dr. John Kevin at the Papua New Guinea Institute for Medical Research in Papua New Guinea. And we collaborate with many people all across the world, each of the continents, except maybe Antarctica and so on. We have strong collaboration, wonderful support from those from all over, and we're very grateful for that. So what is the foundation, the basis of the current activities of the APMEN Vector Control Working Group? We need to remind ourselves, and I'm sorry I keep harping on this, but I feel it's important to take a step back and look at the context of things. And that is malaria control throughout the tropical world, wherever malaria is endemic. Malaria control relies overwhelmingly on vector control. If you look at the malaria budgets available annually, how much money is spent on malaria control, the bulk of it goes to vector control. Just think of insecticide-treated bed nets, and you'll start understanding why vector control and the money spent on vector control is a very large slice of the activities and the budgets and focus of malaria control programs. So, if you're going to rely on vector control as your primary strategy for malaria control, you better make sure that your vector control program works and works well. Your vector control program relies very strongly on vector surveillance. So, vector surveillance, in other words, things like, you need to know which mosquito species are in a particular area, where they're breeding. You need to understand what is their insecticide resistance status. Otherwise, your control efforts may be worth nothing if the mosquitoes are resistant. So vector surveillance is a very critical element of malaria control. So going back to 2018, there have been a number of studies back in 2018 led by people like Tom Burcott and who did a global survey. There was another survey run by Tanya Russell, and these were published in Malaria Journal back in 2018 to 2020. Capacity of national malaria control programs to implement vector surveillance, a global analysis. So these were global surveys to understand how effectively national malaria control programs are conducting their vector surveillance programs, and what are the gaps and needs and shortfalls associated with that. They found that at global scale, including Asia Pacific, there were very significant and serious shortfalls in vector surveillance. This was confirmed by every year since then, when we hold our annual conferences, when we hold particular workshops. We always try and build in sessions to invite our national malaria control programs to tell us what are your priority needs and shortfalls and gaps that you would like the APMEN to help you with. Vector surveillance capacity strengthening is always right up there as a very top priority. So that was back in 2018 that the initial round of surveys were done to understand gaps and needs and shortfalls. So last year, 2024, APMEN decided in collaboration with PACMOSI down in Australia to conduct a follow-up needs assessment across all 22 member states of the Asia-Pacific Malaria Elimination Network, APMEN, to see if those needs have now been satisfied. We can now move on to something else. Dr. Porn, Dr. Ponsihain, he led that initiative, and he pulled together the results and produced this series of individual country reports that captures the outputs of that survey, which again showed, and it's summarized in a one-page document, which you can access at this website over here on the apmen.org website, that collates the core elements indicating the status of vector surveillance and vector control in each of the 22 member states. And once again, it shows that there are critical shortfalls and a great need, a continuing need for capacity strengthening in vector surveillance. So this is what guides our working group, is that what we listen to what the country national malaria control programs are telling us, what they feel their priority needs are, and then we respond to that. So what are some of the typical interventions that we have implemented to address that expressed needs that come from the national malaria control programs? So it is clear that there's a great shortfall of entomologists, people trained in basic entomology across the region. So we thought, okay, we'd start off with trying to increase the number of people that have basic qualifications in entomology. So back in 2019 already, APMEN sponsored 4 Asia-Pacific representatives for a 5-month diploma in applied parasitology and entomology course held at the Institute for Medical Research in Kuala Lumpur. These are the 4 people over here. Sorry about the gender balance. I wasn't involved in the selection, but I'm sure it was done according to merit and by nomination from the various countries. So these 4 people were trained, but very quickly you realize, you're training 4 people. It's very expensive, very time-consuming. It's a drop in the ocean. So we looked at alternative models and decided rather to hold shorter courses, more intensive courses, and the model we came up with is a 2-week intensive in-person vector surveillance course that covers all the different aspects of vector surveillance. How to identify mosquitoes, how to collect mosquitoes, how to sample populations, how to test for insecticide resistance, and so on. All those different elements were built into this intensive 2-week training course. And then we'd invite 25 people nominated by countries from a specific region, whether it be South Asia, Melanesia, Greater Mekong sub-region. We'd rotate them year by year, invite 25 national representatives from that region, bring them to a central host institution that has the expertise available to train those people, and then we put them through that 2-week training course. So the most recent one was held here in Bangkok, 23 June to 4 July, and that was the 6th, number 6 of these courses. And again, then 25 national delegates. I'm not sure if you can see my cursor. And then, it's not just laboratory training and lectures and so on, but it's also field experience. We take them for a few days out into the field, and we let them hands-on experience in actual mosquito population sampling, larval sampling, adult mosquito sampling, cap surveys, etc. And then it results, each year we also then produce a report that captures the proceedings of that particular training course. We also have shorter 5-day in-person training courses periodically, for example, such as on PCR and ELISA, vector and parasite identification course. This was held last year in Pakistan. Again, we invite a number of participants based on the capacity of a particular laboratory to host those people. Excuse me. And then to supplement that, we have online courses as well. Every year we have these online courses where you can reach a greater number of people with less cost involved, such as an online course in GIS over 4 days. That was back in 2021. But as I say, we have these courses every year on different things. These are just examples that I'm highlighting. Most recently, in August this year, we contracted Professor Neil Lobo. Many of you will be familiar with Neil. He is, in my own opinion, and agreed on by many others, the world's top exponent, the world's top expert on vector surveillance in the theory and practice of vector surveillance in the world. So anyway, got Neil to hold a training over 3 days on vector surveillance, an online course. And just to show you the enthusiasm and participation on day one, this is an online course now. It's not the number of people who registered, it's the number of people who actually attended on a particular day. 1,252 on day one, and then around about 1,200 on each of the subsequent 2 days. So very, very popular, well attended, clearly a great need and desire and interest in having these courses. At the end of each of these courses, we have a poll to get our audience to tell us what they feel the value and benefit and relevance of those courses have been. And always overwhelmingly, the type may be too small, but you've got to combine the red and the blue to arrive at interpreting these pie charts. Extremely relevant is blue and very relevant is red. So you combine it and you see that more than 90% of people are very, very satisfied and happy with the courses. Then to further expand our reach and share information and knowledge about vector surveillance and vector control, we have regular webinars dispersed throughout the year. This one was to coincide with World Mosquito Day back in August. There was a webinar there. And for each of these webinars, we ask top people across the planet to give presentations on a particular theme. So we select a theme and then we invite top experts on that theme to give presentations. And we do this multiple times across the year. They've become very, very popular indeed. For this one, mosquito-borne diseases on the rise, drivers of change, and the need for integrated action. Just to give you an idea, out of the 556, there's not many webinars that attract a total of 556 attendees. So again, it just shows you how popular these webinars are. And it shows you that of these 556, now I've lost my cursor, there's a good gender balance spread. 35% were from the 19 APMEN countries. 31% were from government sector, and that's our target audience primarily, national malaria control programs. So most people, 98%, rated the webinars excellent and good and so on. So we also contribute to development of newsletters. My apologies for that. So regularly contribute to APMEN newsletters. This one back in August this year had a focus on outdoor transmission For those of you who may know him, Michael McDonald in his younger years when he was young and handsome and active in the field. We also have annual conferences. Some years it's a virtual conference. Some years it's an in-person conference. So we were going to hold a virtual conference this week, in fact. But for various reasons, it was decided, let's rather postpone it until April next year. So next year, April, we will have a joint, all three working groups, joint annual conference in person here in Bangkok. So no conference this year, but we will have a very good one next year. Also, another kind of activity is capacity strengthening for improved vector support to forest goers and remote populations. This is a learning visit for countries in the Melanesia region, Papua New Guinea, Solomon Islands, Vanuatu, Timor-Leste, Papua province of Indonesia, that have particular problems and where, except for Timor-Leste, where malaria is not declining as is in the rest, much of the rest of Asia Pacific. There's a problem in Melanesia with getting malaria to decline. So get a bunch of people from that region, field entomologists, to come and visit Cambodia in February next year to learn from the Cambodian experience. Cambodia has been extremely effective in bringing down malaria, especially in remote, hard-to-reach populations in the border areas. So get those Melanesia people to visit Cambodia and learn from them. So exchange visits to benefit particular problem areas. We've also provided support to the climate change interest group. Dr. Porn is going to report on their behalf separately. We've also supported the outdoor transmission interest group, just woven in a few slides on that. My apologies. The outdoor transmission interest group had activities such as the recent webinar in September, a couple of months ago. They had one on outdoor parasite transmission, which is a challenge for malaria control. Malaria transmission, much of the remaining residual transmission takes place outdoors. And we don't really have tools to address outdoor biting. So this is a very important topic. Again, this webinar attracted a lot of attention. 456 people actually attended the webinar. And again, very high level of interest. Also, there's a case study which is very near completion. Now, outdoor biting by malaria vectors, what are our options for intervention? The case study that should be out within the next few weeks. Our vector control working group provided support for a small project to the interest group on outdoor biting and resting behavior of malaria vectors in Papua New Guinea. This produced a final project report in April this year. Excellent findings there. So just a summary of some of the outputs of the vector control working group. 6 in-person 2-week malaria vector surveillance for elimination courses, those 2-week courses I was talking about. Trained 134 entomologists from 21 APMEN countries, National Malaria Control Program. Online course training for 4,000 people globally. Always about 60% of the participants are from the Asia Pacific region. 31 webinars that were organized and run by the Vector Control Working Group, shared information with more than 9,300 people globally. And although it's a global audience, we get people listening in from North America, South America, Africa, Europe, very well attended. But at least 60% of those participants are from our prime target area, which is the Asia Pacific region. So what is the big picture summary? just some general thoughts on the current malaria and vector situation in Asia Pacific. We have problem spots of persistent, escalating, or high burden residual malaria in Pakistan post-flood event. Pakistan was making amazing progress in reducing its malaria burden. Then it had that flooding episode back in 2022, and it's battling to get malaria down again. Then, because of the situation in Myanmar, Myanmar is battling to bring down its malaria burden, and in fact, it's spilling over with the refugees and impacting on Thailand's objectives to reach malaria elimination. So there's significant numbers of malaria cases entering Thailand. So that is a problem. Papua New Guinea, Solomon Islands, I mentioned, there's a problem there. Remote populations in the valleys, very difficult. A large part of central Papua New Guinea is very mountainous, very difficult to reach those populations. So very difficult to implement malaria control. Then there's also simian or non-human primate malaria, Plasmodium knowlesi, etc., with a focus in Malaysia, but also in several other countries. My apologies. But there are bright spots, such as, well, we all know that China managed to reach malaria elimination. It's registered as locally free of local transmission, certified by WHO. Timor-Leste very recently followed that example, together with Sri Lanka. Cambodia, Laos, Vietnam are well on their way. Congratulations to them for the great successes they are achieving. And then bright spots is spatial emanator field trials. I've mentioned this because spatial vector control is largely, the world looks at WHO, World Health Organization, for guidance as to what tools should be implemented. The only tools that WHO really recommends, unqualified, for vector control are insecticide-treated nets, ITNs, and indoor residual spraying. Both of those are for indoor application. WHO has now also very recently, around about 15th of August, it approved the use of spatial emanators, but again, specifically only for indoor use and together with either ITNs or IRS. And then also only two specific products, which are Mosquito Shield and Guardian, both of which are based on transfluthrin. Those are the only two products that are pre-qualified by WHO. So now we have 3 WHO. Larval source management is also endorsed by WHO for specific conditions, breeding sites that are few, fixed, and findable, but it's a qualified recommendation. But it's a bright spot. At least spatial emanators are now joining ITNs and IRS for control of at least indoor biting. We still sit with a problem of outdoor biting, which is a serious challenge. Thank you for your attention and patience. Thank you, everyone.
Thank you very much, Dr. Muta and Dr. Leo, for your in-depth insight and wonderful presentation. So this time, I would like to hand over to the Vivax working group. So Dr. Gary and Dr. Manish, over to you.
Thank you. Thanks, Dr. Prone. I hope that's visible to everyone. So I'm Carrie Lynch, co-chair of the Vivax working group. I'm presenting on behalf of Dr. Nina Berecha. She can't be here today. She's at the RBM board, so she wasn't able to join us, unfortunately. And you'll hear from Dr. Manash Shrestha, our coordinator, later on in the presentation. So how do I make my slides go? Okay, so I just wanted to give an overview of where we are at in the Asia Pacific, and Professor Leo already alluded to this in his presentation. On one end, the Asia Pacific is closer than ever to elimination in some countries, yet it faces renewed surge in some high burden areas. So we have 5 countries that have eliminated and are sustaining elimination, and they are really big inspirations, I think, for some countries in the region who are then close to their targets. So we have 7 countries that are achieving momentum. They're close to their targets. It's within sight and possibly one of the hardest times of the whole malaria elimination campaign. And then we have 6 in which we're seeing resurgences. In terms of the parasite species that's dominant, we have got a Vivax dominance in the region, which is the reason for the Vivax working group. But thankfully, we've got recommendations coming out from the WHO Global Malaria Programme in the last couple of years with this ongoing living guidance. And so we're seeing this fantastic pipeline of new tools coming down the way and research coming out, and that's being incorporated into the WHO GMP guidelines on an ongoing basis. So with that, we've seen, for example, that at least 13 countries in the region are fully implementing, piloting G6PD point of care tests. So that's a kind of safety aspect of Vivax radical cure for the 8-aminoquinoline treatment for Vivax. We've seen a revision of national treatment guidelines for PQ7 higher dose, which was recommended by WHO last year, which also requires the G6PD testing in at least 7 countries. And we're seeing implementation or regulatory approval or piloting of tefenoquine in 6 countries. And these are the 6 countries that are using chloroquine, which is what tefenoquine needs to be used with. Tefenoquine, for those of you, I noticed that there's a lot of people from African countries, from Senegal and Kenya, welcome. But for those of you who don't know, this is a single dose cure for Vivax malaria given alongside chloroquine, which is quite a revolutionary treatment. But as I said, we're seeing a huge resurgence in cases. And this is just a point of note. It's not caused by falciparum, but it's in a lot of countries where they have falciparum co-endemicity, which is of concern to us. So we're seeing an uptick. The resurgence is driven predominantly by Vivax, but we do see an increase in falciparum cases in some countries. And our colleague Dr. Mukhtar will know well in Pakistan with the floods, as Leo mentioned, quite a big resurgence of falciparum there, as well as a huge resurgence of Vivax. So that's cause for concern for us. And as I've said, that's concentrated in 6 countries in the region. So just as a recap, much like my colleagues have done, I just wanted to highlight where we're coming from as the Vivax working group and what we're doing. So our first objective is to identify the National Malaria Programme priorities. So just to give, I wanted to give credit to the huge amount of work that was done. As Dr. Pone said, the Vivax working group was one of the earliest groups established, hosted by Menzies before we took over, and they generated a lot of research work on Vivax radical cure and diagnostics. When MMV began to host the Vivax working group, our priority was to then move all of that research into implementation. And to do that, we wanted to first identify, well, what is it the national programs are concerned about? What are their priorities in terms of Vivax radical cure? So we did that in quite a systematic way in 2021. And now we do kind of touch bases with national programs to really stay on top of what their priorities are to try and shift our strategy accordingly. We also work on accelerating implementation, and often this comes in the guise of smaller pilots that can then be used to do some technical advocacy and pull in larger sets of resources for a larger scale up. And I'll go into more detail on that in a second. We try and facilitate learning and information availability. So we do a lot of the peer-to-peer cross-country learning. I'll go into more detail on that in a second. And we try and communicate with evidence. And so we're trying to not just learn from country experiences, but also identify what research is going on at the moment that might be important for national malaria programs to know about. So what are our partners doing in the research world that national programs might want to consider for their policies? So we try and keep an eye on all of that evidence to represent it back to the national programs for their decision making at the national level. And Dr. Minash will go through some updates on that after me. So just to kind of narrow in on the activities that we've done in the last year or so, as I said, we focus a lot on G6PD pilots. We're doing a couple, one in Nepal, one in Pakistan. We're doing some scoping work on Malakit, which is a test and treat kit for mobile populations. We're also working at the policy level, and this is about kind of bringing the evidence together for national programs on an options assessment toolkit, the initial version of which was co-developed with national programs from Afghanistan, Vietnam, and Solomon Islands. And I'll give you more information on that in a second. And then regionally, as both Richard and Leo have spoken about, we participate in annual meetings. With our face-to-face meeting coming up in April next year, we undertake tech talks to try and share all of the latest research and go into a bit of a deep dive, understand what the country perspectives are, what WHO GMP perspectives are with regards to those. We do these peer-to-peer exchanges. One example recently is where we brought together Thailand, Laos, and Cambodia to talk about the experiences with tafenoquine and safety aspects and pharmacovigilance, which the Laos program we're particularly interested in. And then we generate evidence briefs and synthesis. And one piece of work we did in the last year, which was particularly kind of making us open our eyes a little bit more as to what else can be done in the region for those high burden countries, was we've done a review of all WHO recommended strategies. So not just the treatment and the diagnostics, but all strategies they're using to try and reduce burden in different regions of the world, to identify what evidence is available for those strategies' impact on Vivax malaria, what could be done in this region, bringing some of those experiences from other regions. So just to give a little bit more detail on those, so the early implementation pilots, as I said, they're designed really to allow for learning, check feasibility, and then have information for national programs to advocate either within a Ministry of Health or to external donors to go for scale up. So we're doing this in Nepal with CDMI-TU, and which is the national program there. And we're working on a small pilot in a few facilities, and then we're also trying to complement longer term, medium term work by path to scale up that G6PD as well. In Pakistan, we did the same thing last year. We tried to look at the implementation of G6PD in 3 provinces with different burdens of malaria. And this was a step in a larger plan that was initially put together under the Partnership for Vivax Elimination activities, with Dr. Mukhtar leading and bringing together all of the prevention malaria programs to set out a roadmap for Vivax elimination, given its dominance in Pakistan. And this is pre-floods. And so this G6PD pilot was a step towards then tafenoquine pilots and tafenoquine scale up in the country, which has been approved by the regulatory authority in Pakistan, and kudos for their move on that. The next is the options assessment toolkit. We know very clearly from the HIV world that the more, and I think just as humans, right, the more choices we have, the slower the decision making can be. And so in recognition of really the amount of new tools coming down the pipeline for Vivax malaria, we did a piece of work with Menzies, led by Menzies and Kamala Threemer and Vijay Shrestha, to try and identify a systematic way by which national programs could decide which of these new tools are feasible and would be most effective for their epidemiological, political, and kind of risk aversion context. We developed that, co-developed it with the NMPs in Afghanistan, Solomon Islands, and Vietnam. We've just finished an evaluation of the version 1, and we're moving on to then expand that options assessment toolkit to all malaria case management, so for falciparum as well. So finally, we have these innovative ways to reach the unreached. We're doing a series of access workshops with national programs, which we started at the working group meeting last year, to try and identify this is in response to the priorities the NMPs highlighted to us. How is it that we can access the last populations that are potentially reservoirs for Vivax malaria? So we're doing a series of workshops with the national programs to test out different ways that are feasible within their countries. And one of these ways is this Malakit test and treat for mobile populations that has been used in French Guiana in Latin America and is currently being piloted in one small state in India. And we've been doing some scoping work to identify within the Thai framework whether this is feasible to use in Thailand. So that will hopefully build up into a proof of concept piece of work next year in Thailand. And this is an example of the kit they used in French Guiana. So it's got 3 rapid diagnostic tests. There they had ACT treatment, and they have some information as to how to do the test and how to take the treatment. We provide training guidance and technical support, obviously like our other colleagues in the other working groups. We're always here to provide technical support. We have a repository on the VivaxMalaria.org website and some on the APMEN website of training materials, of briefs, of bringing together any information we can on different strategies and treatments. And so in Thailand specifically, we built a modular set of training materials, and this is built up, again, off of the Partnership for Vivax Elimination work. And we're also trying to gather some evidence together on patient adherence to malaria treatment, looking at different duration of courses, including ACT for 3-day, 7-day, 14-day, and 8-week, just to see what interventions have been effective to improve patient adherence. And we're doing the same kind of review for malaria prevention. So how much do people stick to preventive treatment for MDA and SMC, for example? I'm going to hand over to Dr. Manash Shrestha to give you an idea of other work that's not MMV funded work, but other work that's being done in the region, which we think is very key for national programs to have on their radar in terms of policy decisions in the next 2 to 3 years. So Manash, I'll hand over to you and just let me know when you want me to move the slides on.
Thank you, Dr. Carey, and warm greetings to all of our participants today. In addition to what Dr. Carey just mentioned about our work at the APMEN Vivax Working Group, there is a lot of work ongoing from different partner organizations and researchers on Vivax malaria, which we think is relevant for all of our audience, particularly the NMPs. And we would like to take this opportunity to go through some of them so that you can be aware and expect some new evidence in the future that can assist your decision-making for policies in your countries. Let's start with the ongoing tafenoquine studies. Tafenoquine has been pre-qualified by WHO and recommended by WHO last year, particularly for South America and in controlled deployment elsewhere. The 300 milligram tafenoquine, there are conversations as to if a higher dose of tafenoquine might be more efficacious, and there are a few studies that are looking just at that. The first one is the CDOT study, which is led by Dr. Cindy Chu in Cambodia, Laos, Thailand, and Vietnam. And she's looking directly at comparing the 450 milligram tafenoquine with the 300 milligram tafenoquine. Similarly, there's another study called TADOR, led by Professor Kamala Threemer, which is looking at a different weight-based tafenoquine dosing, and she's comparing them with 300 milligram single dose tafenoquine and 7-day primaquine in Brazil, Ethiopia, Indonesia, and PNG. She is here in the audience. If you have any questions, you can directly ask Dr. Kamala as well. There's another research, interesting research on ACTQ trial, where Dr. Ong and the SMRU are looking at the 450 milligram of tafenoquine when compared with different ACTs versus chloroquine. And a similar study is about to start in Thailand, which is known as the tafenoquine combo study from AFFIRMS, which is looking at comparing the efficacy of 300 milligram tafenoquine with different combinations of ACTs. Since tafenoquine right now is only recommended with chloroquine, these studies will expand the use case, see if tafenoquine can be, the use case of tafenoquine can be expanded. Next slide, please. But a relevant and a recently concluded work that was the EFFORT study, also by Professor Kamala Threemer Menzies. And we had a tech talk on this one in May this year. And she presented the the overall findings of the study, which shows that the high-dose primaquine 7 days and single-dose tafenoquine does outperform the standard 14-day primaquine regimen in preventing Vivax malaria relapses. And safety of both of these regimens were excellent, particularly for the disease-free normal participants. And we have this tech talk. If you missed this, it's on YouTube, so you can go back and look at that. And the preprint is also available, and the publication is about to be published as well. So next slide, please. And there are some relevant different streams of work happening in Vivax malaria. First is the serotype work from VISPA. VISPA is the Vivax Serological Partnership, is a platform of different organizations led by Weihai, London School of Tropical Medicine, and Burnett, who have developed an innovative serological testing that can inform both current and past infections of Vivax malaria up to 9 months. So it gives a proxy for hypnozoites, which has been a big bottleneck for Vivax malaria diagnostics. So maybe, and they have outlined different use cases for the PV serotype, which stands for plasmodium vivax serological testing and treatment for interventions and also for surveillance. And this could be one innovative and interesting work that can be a part of all the prevention of reintroduction and different elimination strategies in our region. The other interesting work is expanding, again, the use case of tafenoquine in mouth drug administration in Myanmar. This has been conducted by Dr. Ong again from SMRU. I think they've just finished the initial intervention, and they're looking at follow-up of the patients. We will get him on our TikTok soon, but if you're interested to listen to his initial results, there is a webinar, the ECRIM webinar on 20th November. So that is happening there, and you can see what was the results of using tafenoquine with VxWG testing in a mass setting. And also a similar research is being planned in Peru. So there will be some additional evidence for MDA with tafenoquine in the future. Next slide, please. And apart from these, there are further MMV supported work beyond our APMEN umbrella that MMV is doing in this region. First is the Cambodia MDA with chloroquine, and we're also partnering with IPC Weihai and Burnett on the PV serotype integrated with reactive case detection. And we're looking at feasibility of these two strategies and costing. The results are expected next year.
I'm happy to hear.
We have some disturbances there, but never mind. And we also know that there is some sensitivity towards pediatric version of a formulation of any drug. So we're looking at acceptance of the caretakers for pediatric formulation of tafenoquine and primaquine using a qualitative study in Chiang Mai. And the results are also expected next year. So please look out for that. And currently, MMV is also working with different partners in India to look at the feasibility of disability testing and also a phase 3 trial with tafenoquine. Similarly, scope studies are looking at high dose of PQ7 in Indonesia and Papua New Guinea with different partners there. And we're also looking at trying to scope the feasibility and acceptance of community IPTP in addition to the IPTP at ANC, particularly in PNG. So this could be a better way for the pregnant woman to access the IPTP. And there are different feasibility studies with VxWG and tafenoquine, particularly in Vietnam, which is being collaborated with PATH. So please look out for these studies that are coming out, and we will try to get them in form of different information pieces or TikToks to you in the future as well. And with this, I'd like to hand it over to Dr. Carey to get us to our new vision and our next steps for next year.
Great. Thanks a million, Manesh. So for next year, next steps are, we've got some upcoming tech talks. We're going to do some G6PD lessons learned. MDA and radical cure. We know that we've got colleagues here in Thailand and in other countries working on that. We'd like to explore that as an option and understand what national programs think of that approach. And then raising the awareness around the WHO recommendations on primaquine use in pediatric and breastfeeding women for radical cure. So we'll arrange a tech talk just to kind of highlight that WHO recommendation, which kind of might have slipped under the radar a little bit. We'll be finalizing the pilots and disseminating the results for that, and then obviously doing some technical advocacy to move to scale up in different countries. We're pivoting, as I said, on the options assessment toolkit. We're going to expand out to all malaria case management options, acknowledging that we have those 6 countries where there's resurgent malaria with falciparum coendemicity. We want to obviously keep updating what we understand of the ongoing research to make sure that the national malaria programs are aware of what's coming down the pipeline. And then that's got some synergy with the options assessment toolkit, because that information would be used in there too, because there's an awareness raising component of that toolkit. We'll obviously maintain coordination with APMEN, with APMEN, our fellow working groups, but also with other regional stakeholders who we try and talk to regularly to understand where they're from, including the Therapeutic Goods Agency of Australia around regulatory issues, and WHO regional offices as well. And then, as my colleagues have mentioned, the joint working group meeting coming up in 2026, to which we hope to see a lot of you there. So I just wanted to say many thanks for joining today from all over the globe. It's very motivating to see who's joined. I did want to ask, and we do want to ask, is whether there's any topics that we talked about today that are of interest to you that you want further information on. Please get in touch. For national malaria control programs, or programs in particular, are there priorities that you think are not being addressed around malaria case management? And if so, please contact us and talk to us. Or are you a researcher working in an interesting area? Are there studies that we've missed that are going on in the region that national malaria programs should know about for malaria case management? Again, please get in touch. Our contact details are there. Obviously, you can contact us through Dr. Pone. There's a vivaxmalaria.org website, which MMV hosts, and where we try and put together a lot of documentation as a knowledge hub for radical cure. And then, of course, there's the APMEN website, onto which you'll find our blogs and information about various tech talks and things like that. So with that, I'll close. Thank you very much.
Thank you very much, Dr. Kerry and Dr. Manish, for your great, excellent presentation for the Vivax Malaria. So we have one presentation left. So this one I would like to present because the climate change, environmental change, and malaria interest group chairperson is in the trick, so he cannot use the internet. So I would like to present on behalf of her. So I will present for the APMEN Special Interest Group, Climate, Environmental Change, and Malaria on behalf of Dr. Kimberly Fonis from National University of Singapore. So as we all know that we have increasingly clear evidence that climate change is reshaping our world. Asia is warming twice the rate of the global average, and we are already feeling the changing reality from increasing the heat wave like El Nino and rainfall. Another presentation. So on the ground, this means more frequent flood and landslide, and we are seeing increasing number of extreme weather events like rising the sea level and the prolonged heat waves and droughts. So these changes are already affecting millions of people in our region. Many of these processes are impact infectious disease transmission. As you will see, the climate-sensitive diseases such as malaria and other vector-borne diseases. So this leads to shift in seasonality and changes in geographical distribution. And also the range of the diseases, such as movement of the mosquito to the higher elevation area, and the changes in the timing of the mosquito biting, intensity, duration of the outbreak. So these are underpinned by impact on health and economic system, human behavior, migration, and other determinants of the disease control. So how about the APMEN climate, environmental change, and malaria in special interest groups? So so we want to know the question that what are the impacts of the climate and other environmental change on malaria in our region, and also how national malaria programs adapt to the changing environment, and what about the opportunity to mitigate climate and environmental changes. So the interest groups organize a series of webinars. So you will see the 3 webinars are hosted by the Climate, Environmental Change and Malaria Special Interest Group. So those webinars are really focused on including like climate and environmental scientists in the webinar, and the webinar highlight the cross-disciplinary learning and collaboration. And also the interest group hosted the workshop in Singapore. So this workshop was participated by 33 government officials and technical experts from the 11 countries. So this workshop really highlight and then explore the adaptation of the climate change and waterborne diseases, and what are the priority of the climate change impacts on waterborne disease control. And also we prioritize the impacts addressed by existing evidence and adaptation. Another one is that we developed the APMEN case study highlighting the adaptation strategy to mitigate the impact of climate and environmental change in waterborne diseases in Asia-Pacific region. So this one includes a best practice from a lot of countries from our region. So what about the priority impact of climate change on malaria control? It will be the extreme weather event. So such as like 2022 flood in Pakistan, leading to malaria resurgence, and also destruction of the water control and human migration, and also human behavior changes. So human behavior on the water storage and disposal during the emergency, and then utilization of the mosquito nets. And also the impact on the climate on wildfire and deforestation and movement of cities, like a people movement and to the new settlement. Then finally, but it's not the least, the financial gap and committing priorities are really, really crucial and impact on the climate change on malaria control. So for the adaptation for climate change and malaria, so we need to advance the policy framework and head adaptation planning. And another one is that we have to increase the digitalization of surveillance system. And we noticed that the gaps are really remained for the combining the climate information to the disease control. Another one is that community engagement is really successful for across this region. And finally, as I mentioned before, funding is remain a huge challenge. As we all know that global health financing landscapes are changed. So this is the really urgent regarding to the funding to respond to the climate disaster. So how about the next? So we need to focus on the increased engagement across the region to highlight APMEN is a success in the WHO ETEC program. And also we will highlight in the case study and success story for adaptation. And also we will link the climate, regional climate scientists and national malaria program for the waterborne disease control program. Now we will do, we continuously during the training and webinar. So please stay tuned in 2026 events. So this is the end of my presentation on behalf of Dr. Kimberly Fornes for interest group on climate, environmental change and malaria. So now I would like to go to the question and answer session for around about 10 minutes or 15 minutes we have. So I noticed that a lot of questions come in the chat box and then question answer box, and then some people want to be part of the network. So as I mentioned before, this is a collaborative platform with the National Malaria Program from 22 Asia Pacific countries and 54 partner institutions. So partner institutions are really diverse. That include academic and research institutions, some government institutions, NGO, private sector, UN agency, and donor as well. So APMEN strategy is really focusing on peer-to-peer collaboration. It means that one country needs some kind of help or support. We link with another country that has that kind of experience, or we link with the partner institution or expertise in the network to support to the country. So it means like peer-to-peer collaboration, country-to-country support, or partner-to-country support. So another one is to respond to the question in the chat box. So we usually announce the training opportunities and webinar through emails and also our social media and website. So please follow our LinkedIn and social media to know the update training and webinar opportunities. And also, I have noticed that one question related to the new working group to focus on the malaria-free certification, integrated health system, and sustainability. So for this question, we are also thinking to re-establish the APMEN Program Management Working Group. So APMEN Program Management Working Groups can focus not only to strengthen the capacity of the program management of the national malaria program, but also that like cross-thematic issue and emerging issue. So those are really essential for malaria elimination. So now I would like to pick the question and ask the Professor Richard. So Professor Richard, we would like to know that what are the most effective cross-border collaboration strategy to prevent malaria importation or to prevent re-establishment in the elimination or near elimination country. So Professor Richard, could you please respond to that question?
Hi, Fawn, thank you. Yeah, the first thing to say is I think there's no one best strategy, and the best strategy fits the context very much. It depends on the local context and the situation. We're currently trying to document the range of approaches used across the region with this research that I mentioned, and we'll be sharing findings from that early in 2026. But I think some key things that I think people are probably already aware but have come through this research are data sharing, so sharing information across borders, and communication between countries to understand the current situation, because it can be also quite dynamic, particularly where there's transmission either side of a border. I think that those are critical. Yeah, a lot more to say, but more to come early next year. Thanks.
Thank you very much, Professor Richard. So another question we would like to ask to the vector control working group. So we noticed in the presentation of the Dr. Leo that special repellent. But those are only recommended for indoor. So my question is that what innovative vector control strategy can effectively address outdoor mosquito transmission? So in elimination setting or the elimination setting. Over to you, Dr. Leo.
Thank you, Dr. Pon. So I wish I could give you a quick, easy, simple answer, but the reality is if that there was a quick and easy answer, we would have been implementing it by now. Outdoor biting is a very real and very serious problem, not just here in Asia Pacific, but even in Africa. So there have been some very promising tools being developed, such as attractive targeted sugar baits, which is like a thin membrane bag filled with sugary substance. And then the female mosquitoes, both males and female mosquitoes, need sugar water for an energy source. Females need to take blood for nutrients for egg production, but both males and females need to take sugar. And that's why they go to flowers for nectar and so on. So if you put a toxic substance and you add it with the sugary substance in a thin membraned bag, and you hang it against the wall outdoors or against a tree or something, then the mosquitoes will come and feed that if you have some odor associated with that attractant as well. But it's turned out that the bags denature too quickly. They only last a couple of months, and the cost effectiveness is not so good. So that is turning out to be not, it has its problems. Spatial repellents are still being investigated for outdoor use as well, but the problem is, any slight breeze or so on dissipates the odor, so that's a problem. Topical repellents are in some cases very effective. WHO does not endorse any topical repellents, not because some of them are not effective, but because no study has ever proven that topical repellents has an impact on malaria disease reduction at population level. So individuals who use it, for some brands, it's very effective. But to get a whole population to use it on a sustainable basis so that you get an impact on at village level or population level, especially when people have to pay for it themselves and your average rural person doesn't have adequate resources to buy these on a sustained basis. So trials are still ongoing to try and find something that can be generally applied. One method that is currently being tested by none other than Professor Neil Lobo and his group is toxic impregnated, insecticide impregnated barrier screens, where you put the barrier screen, it's this shade cloth material impregnated with an insecticide, and you put that up between the household and the breeding sites, a stream, a river, ponds, pools, and so on, where the mosquitoes breed. Mosquitoes breed out there. They have to come to humans, and on the way, they touch, and it need only be for 1 second. If they touch that barrier, they pick up enough insecticide to kill them. So that is currently undergoing trials and tests. But the bottom line is right now, we do not have one magic bullet product that helps for outdoor biting. Like I said, topical repellents do help. And there are others as well, insecticide-treated cattle, but very specific situations, specific applications. So we need to wait and see, for example, what happens with Neil Lobo's impregnated barrier screen methods and so on. Sorry, I can't give you a better answer than that, Dr. Pon.
Yes, very comprehensive answer. Thank you very much, Dr. Leo. So we saw some question in the chat box. Before going to the chat box, I have one question for Vivax working group. So how can we accelerate radical cure implementation while ensuring patient safety in area with high or moderate GCPD deficiency prevalence? So Dr. Kerry, you'd like to answer?
Thanks, Dr. Pon. Yeah, I think that's a key question given the challenges with the Vivax relapse. What we're seeing now, as I presented, a lot of countries are taking up the use of the G6PD testing, which we've seen in some countries in particular gives health workers confidence to then use radical cure. Many countries previously would have primaquine in their national policy, but they wouldn't use it necessarily because they were worried about the G6PD deficiency. We're seeing now Thailand, for example, has been implementing tafenoquine for the last year almost at hospital level with good G6PD testing. And when they can identify that enzyme activity, they can confidently give an 8-aminoquinoline like PQ7 higher dose or tafenoquine. Where there's G6PD intermediate and deficient is more difficult. And that's where, for our scoping review, for example, for patient treatment, we see a fall off, obviously, in patient adherence, even after 3 days. Even within the 3 days, we see a reduction of adherence to 3 days. So 7 days is challenging, 8 weeks is very challenging. And I think national programs have to consider when it's most cost effective, where the balance is when they put resources into patient follow-up. And that could be for those intermediate and deficient cases where they put most resources to ensure follow-up of those patients while using a much shorter course in the G6PD normal. So I think the crux of it is having this point of care G6PD test, which unfortunately is quite expensive at the moment, but we know that PATH are working with partners to develop more. And I know, for example, Menzies are clinically validating some other G6PD tests. So I think more will be coming onto the market soon, and that should hopefully reduce the overall cost. Thank you.
Thank you very much, Dr. Kerry, for this answer. It's really interesting. Thank you very much. So I'm going to pick that question from the Q&A box. So Dr. Indra, ask the question. I think it's related to the fata control working group. So the question is that why we are working towards malaria elimination, we cannot get elimination status as long as we have the presence of phenolazine. So she would like to know what fata control methods can be used for the control of zoonotic malaria vectors. This is over to you, Dr. Leo. And also she has asked a question. So I would like to encourage the attendees, you can freely respond the question in the Q&A box. It's open for you. So Dr. Leo, I would like to ask the question that Dr. Indra want to know about the fata control method can be used for the control of zoonotic malaria vectors. Dr. Leo.
Thank you, Dr. Pon. So, whether the vector is carrying the traditional human parasites or the monkey malaria, Plasmodium knowlesi, cynomolgi, or inui, or whatever, that mosquito still has to bite you. So you are compelled to use the same biting prevention, transmission intervention tools that you would, whether it's for non-human primate malaria parasites or for the historic, primarily human malaria parasites. So, I can only re-emphasize or reiterate what I said earlier on, that for indoor control of vectors, you use either indoor residual spraying or indoor the insecticide-treated bed nets, now supplemented with spatial emanators. Those have been good enough to enable many countries across the world to achieve malaria elimination. The problem is they only work for indoor situations. And the challenge is that for the zoonotic malarias, they are overwhelmingly transmitted by outdoor biting mosquitoes. And I explained earlier on that we don't have effective tools for prevention of outdoor biting mosquitoes. It is a challenge. It's a serious challenge. So, I'm not sure I can recommend anything other than topical repellents at the moment. Sorry.
Thank you very much, Dr. Leo. So, as I mentioned before, APMEN is hosted by the APLMA since 2017. So now our CEO, APLMA CEO, Dr. Satha Das, is here to close this update session. So I would like to hand over to Dr. Satha. Dr. Satha, could you please close this APMEN working groups, joint working groups, and interest group update 2025. So over to you, Dr. Satha.
Thank you. Thank you so much. I hope, can you hear me okay?
Yes, we can hear you.
Thank you. I really want to thank, firstly, all the chairs and co-chairs, Dr. Ina, Professor Richard, Messiah, and the Surveillance Working Group, Dr. Mukhtar, Dr. Leo, and Hulan in the Vector Control Working Group, and Dr. Nina, who's here with me at the RBM board meeting, Dr. Carey, and Dr. Manash, and of course you, Pon, in addition to everyone else. Professor Rick Price said to me some years ago, he said, when I was starting, he said, APMEN is not to be violent, but is a double-barreled gun. It's it's something that's extremely powerful together. And I think, watching here at the global level, to watch the RBM partnership and the working groups and the RBM Secretariat continue to work on improving the way in which they can serve countries in the global effort is a reminder that of how powerful it can be. and how it's a continuous process. And so in that regard, I just want to thank our chairs and co-chairs in the working groups for continuing in this collaboration in a time where it's more needed than ever. And I think some of the things that I heard, and I could not join in the very beginning, but I was able to listen in on most of this. And of course, I follow the reports that and the border malaria work of the SRWG, the vector surveillance work, the options assessment that Dr. Carey mentioned, just some of the really wonderful examples of what the working groups are able to do. We know, especially in the high transmission areas, that no one intervention is perfect. And so we really are they're imperfect, right? And so we need to figure out which ones where and how are part of what drives the ability to be effective advocates and effective in our role as being an advocate means what? Means really helping countries find money. And also making sure that this doesn't disappear from the agenda of many of the countries. And so I just thank all of the people who've joined and hope they will continue to join. I think we have incredible potential, as was brought up many times over the course of the webinar, of how much, when we think about this region, as much as it can't be described as a monolith, there is so much to be learned from this region that is now roughly 5% of the global burden. And so the sooner that we can make inroads to accomplishing the goal of elimination, and while it may be quite difficult, I think there's so much that can be done between now and 2030. The more that we can leverage the expertise and leverage resources and channel resources to our brothers and sisters in the African subcontinent, where the majority of mortality and suffering is happening. And so what we do as One World matters so much with all the changes we've seen in the global health architecture. The work of the working groups is more important than ever. So thank you so much for all that you're doing, and sincerely appreciate it. Thank you.
Thank you very much, Dr. Saturday, for your closing remark. So now we close our update. So after 1 day, there will be evaluation survey, just only 4 questions. So could you please respond the questions? So these are really helpful for us to plan. So thank you very much, our Dr. Satat, our chair, co-chair, coordinator from 3 working groups and interest groups chair. So thank you very much, and also attendees. So thank you very much for your active participation. So bye-bye.